Hey everyone, and welcome. Today we're going to break down the key practice-changing insights from that 2018 ACVIM consensus statement on the rational use of gastroprotectants, for our dog and cat patients. This is stuff that really impacts what we do every single day. So let's just dive right into the big question that this consensus statement really forces us to ask ourselves. Are we overprescribing these drugs? I mean, it's a huge question, and the answer really affects our daily clinical decisions and, of course, our patient outcomes. And look, this isn't just a guess. The ACVIM panel makes it really clear that inappropriate prescription is a real documented trend. And it's not just us. It's something that mirrors the exact same challenges happening in human medicine. So this consensus statement is all about giving us a solid framework to start using these drugs more rationally, based on actual evidence. All right, so here's our game plan. We're going to compare the main drug classes, figure out the evidence hierarchy, nail down the clear indications for use, and then we're going to challenge some of those old habits around prophylaxis. And we'll wrap it all up with some actionable takeaways you can use in your practice. Okay, first things first. Let's do a quick refresher on the main tools we have in our gastroprotectant toolkit. We all know these guys well, right? The histamine type 2 receptor antagonists, or H2RAs, things like famotidine. They work by blocking one of the key signals that tells the parietal cell to start pumping out acid. Pretty straightforward. And then, of course, we've got the proton pump inhibitors, the PPIs. Now, these are a much more targeted and, frankly, powerful tool. Why? Because they go right to the source and irreversibly shut down the acid pump itself. It's the final common pathway, so it's a much more definitive block. And rounding out our top three, we have sucralfate. This one works completely differently. It's not about suppressing acid at all. Think of it more like a mucosal bandage. It literally forms this protective barrier right over the damaged tissue, but it needs an acidic environment to work. Okay, so this table really lays it all out for us, side by side. But I want you to focus on that bottom row, key issue. Yeah, you got to taper PPIs, and sucralfate has some drug interactions we need to watch out for. But the real game changer here, the thing we have to talk about, is this rapid tolerance, tachyphylaxis, that happens with H2RAs. And that idea of tolerance, well, it's the perfect lead-in to our next section, understanding the evidence hierarchy, and really digging into why one of these drug classes is now considered the absolute gold standard for serious acid suppression. So here's the deal. This whole tachyphylaxis thing with H2Rs, it's a really big problem. Their effectiveness can just plummet with continuous use, and we're not talking weeks or months. Studies in both dogs and cats have shown this can happen within just a few days of starting treatment. And wow, this chart just says it all, doesn't it? When we talk about meaningful, sustained acid suppression, getting that stomach pH up to where we need it, the studies are crystal clear. Twice-daily PPIs are just worlds more effective than twice-daily H2RAs. It's not even a close competition. And this quote from the ACVIM panel, it basically puts a big, bold underline on everything we've just seen. For treating acid-related GAU, gastroduodenal ulceration and erosion, twice-daily PPIs are our most effective medical tool. Period. Okay, this is where the rubber meets the road. When does the evidence give us a big green light? When can we confidently say yes to these medications? The number one hands-down evidence-backed reason is for treatment. And notice I'm stressing treatment, not just routine prevention. We're talking about active diagnosed gastroduodenal ulceration or significant erosion. This right here is the cornerstone indication. And again, the panel doesn't mince words here. They're saying that for active GUE, PPIs aren't just a good option, they should be considered the standard of care. That's a really strong statement. Now, there is another clear yes from the panel, and that's for prophylaxis to prevent reflux esophagitis, especially for our patients going under anesthesia. Now, remember, it's not that the PPI stops the reflux from happening, right? It just raises the pH of whatever does come up, so it's way less caustic and damaging to the esophagus. All right, now for the part that might make us all a little uncomfortable, because this is where we have to challenge some of those common, almost reflexive prescribing habits that we've all developed over the years. So take a look at this list. I mean, we see these conditions every single day, right? Simple gastritis, pancreatitis, liver disease, early stage CKD. The panel looked at the evidence and found that for these conditions, routine prophylactic use of acid suppressants just isn't supported. Same goes for most cases when we're using glucocorticoids. Let's zoom in on pancreatitis for a second. We treat it constantly, and it's so tempting to just automatically reach for a gastroprotectant. but the evidence simply isn't there to support it, unless you have confirmed concurrent ulceration.
And it's the same story for our stable early-stage CKD patients. The panel actually points out that some studies suggest these animals might not even have gastric hyperacidity to begin with, so giving them an acid suppressant prophylactically is likely unnecessary.
So, after all that, what do we actually do with this information tomorrow morning in the clinic? Let's boil it all down to some really clear, practice-changing takeaways. Here are the 4 big ones. Number 1, prioritize PPIs. When you've got confirmed GEU, twice daily PPIs are your go-to, your standard of care. Number 2, question prophylaxis. Let's challenge that automatic impulse to prescribe them for pancreatitis or CKD. Number 3, and this is so important, always taper. If a patient's been on a PPI for more than 4 weeks, you've got to taper that dose to avoid rebound acid hypersecretion. And finally, number 4, timing is everything. Give those PPIs 30 to 45 minutes before a meal to get the biggest bang for your buck. And you might be thinking, so what? They're pretty safe drugs. And yeah, for the most part, they are, but they're not totally harmless. Being more thoughtful and judicious helps us avoid potential issues like intestinal dysbiosis, which is a hot topic right now, not to mention drug interactions and other potential side effects. Look, at the end of the day, what this ACVIM statement really does is it empowers all of us to move away from this is just how we've always done it and toward making truly data-driven decisions for our patients. It's how we get better. So the question to leave you with is, based on this evidence, what's one prescribing habit you'll reconsider this week? Thanks so much.